Again, and here's the thickening was along the anterolateral wall rather than the anteroseptum and septum. As you may see, there is excessive trabeculation. This is a recent case, and we were not sure whether this is just excessive trabeculation or there is coexisting non-compaction myocardium. Another form of dumbbell-shaped septum and hypertrophy again along the lateral wall on the basal level. Screening, there are different types of screening, one of which is the family screening. And it's important to detect the subclinical cases through screening family members of patients who being diagnosed as positive HCM. Family screening could be through MRI or echocardiography, and then later on gene testing, because sometimes, for example, in this case, father got positive HCM, but the daughter negative phenotype, but was positive on the genotype. In children, usually screening starts at 12 years old, every 2 or 3 years, until maturation, and may extend for 5 years. And this is in order to detect any trend of being positive phenotype HCM, and could either echo or MRI. One of the important screening types is the athlete screening. It's very common cause of death on the pitch in between the sports members is HCM. So detection of those cases could lead to disqualifying of a sports member. So it's important to screen those cases, and we could differentiate through MRI between HCM and athlete. Athlete usually are the ventricular size, atrial size on the uppermost normal level, good or normal systolic function, not the supernormal, no crypts, no late enhancement, and the wall thickness usually is below the 12 millimeters. And even if it's increased due to some steroids or anabolic use, then we could recommend to stop the steroids, anabolic abuse, and then perform a follow-up after 3 or 6 months to see the trend of regression of the wall mass and wall thickness. An MRI, of course, could provide satisfactory solid numbers during follow-ups of those cases, measuring the wall thickness and the wall mass. Stratification of sudden cardiac death, not only detection of late gadolinium enhancement, but also the amount, and we have the cutoff values for defib implantation if there is an involvement of more than 15%, because this is highly correlated with arrhythmias. Again, obstruction, whether the obstruction is at the outflow tract level or in the mid-ventricular level, this carries a high incidence of cardiac events and cardiac arrhythmias. For example, in this case, we could see the jet of the outflow tract obstruction. And not only about the outflow obstruction, but also MRI could give hints about the anatomy of the papillary muscles. And of course, this is through the 3D visualization of the heart, as well as good satisfactory quality and resolution between the myocardium and the blood pool. For instance, this case was, this patient was a candidate for alcohol septal ablation, and then the MRI revealed one of the papillary muscles was passing through very close to the potential site of the alcohol ablation. This patient was excluded from alcohol septal ablation because of the papillary muscle anatomy detected on MRI. We could detect any post-intervention complications or changes, myocardial edema, hemorrhage and MVOs, any residual LVOT obstructions. Same we could see post-myectomy. So this patient before surgery, LVOT obstruction, velocity is 3.9, and this is after, where there was no obstruction and no jets. Follow-ups, of course, it's important to follow up those cases, because sometimes, and this is in rare occasions, as you may see, that the systolic function has decreased massively and that was a burned HCM case. That was the same case, and of course, as you may see, the massive fibrosis 2016 and 2019, and probably this is the cause or this is the reason why this patient experienced this. So that this 2016 and this 2019, and this massive fibrosis might explain why this patient underwent the burned out myocardium. Differential diagnosis, hypertensive, and I think we have discussed the hypertensive cardiomyopathies in previous presentations. Usually it's on the volumes are on the high side, function on the lower side when compared to the HCM. Enhancement is usually patchy in HCM, but he usually is along the septum or along the lateral wall, mid-wall linear enhancements. Amyloid, where there is, of course, dilatation of the atrium, diffuse wall thickening, and of course the kinetics of contrast is really important. As you may see here, that the myocardium is being nulled before the blood pool, which is a diagnostic sign of amyloid. That patient was amyloid. Contrast enhancement extends to the atria is one of the diagnostic signs as well. This patient got also pulmonary edema. Connective tissue diseases, so this patient and her daughter tested positive HCM and they suffered from interstitial lung fibrosis, sent for an MRI to see any cardiac involvement, and then MRI revealed this wall thickening. Genetic testing later on revealed both mother daughter are HCM positive. Mucopolysaccharide in children, the deposition of the abnormal material, usually at the aortic valve level, mitral, they cause severe stenosis and then hypertrophy. Many cases are being sent from echo as being diagnosed as HCM, but MRI usually later on reveals mitral valve prolapse with mitral annular disjunction, separation of the mitral annulus from on the myocardium from the mitral annulus, which is called the mitral annular disjunction, with secondary regurgitation, hyperdynamic base with some thickening at the base, but they are negative for HCM. Fabry disease and the T1 MAPS plays a major role in the diagnosis of Fabry in the early stages, where the T1 maps are going to be on the lower, below the normal values, but later on with the fibrotic stage of Fabry, it might go high up, but in the early diagnosis, usually intracellular deposition leads to T1 maps below the normal values. Of course, the T1 maps, as you may all know, measuring the extracellular volume, tagging in order to measure the deformation of the heart, but now there is the deformation feature tracking, where it detects the movement of the pixels in order to measure the global systolic function, and the global systolic function may help to differentiate between HCM and the different differential diagnosis. Now this is coming in the MRI and under research for MRI applications. Stress also, as you may see here, this is the stress study and this is the rest. Perfusion defect, subendocardial in many territories, which correlates with subendocardial or microvascular dysfunction. Now in literature they are describing the importance of detecting microvascular dysfunction in HCM in order to predict cardiac events. We are running a study about the ventricular arterial coupling using MRI to non-invasively measure the ventricular arterial coupling pre and post myectomy to see how important and the changes not only in the ejection fraction but in the ventricular arterial coupling at the moment. Of course, without any bias, MRI has some disadvantages like any other modality. MRI now is in the guidelines since 2010 in the management of HCMs. And thank you.